what information we could improve on, what documentation we're lacking, some diagnoses that we're missing, some low-hanging fruit diagnoses that we're missing. I know the obesity is a big one. Our overall goal is to improve our documentation, our patient outcomes, and to receive accurate reimbursement for our services that we're providing to our patients. So I'm going to let Marquita take it from here.
Well, first of all, thanks. I know you and Donna have worked hard on getting this scheduled and sending the questions. And so we've tried to go through, or the team has tried to go through and answer them as best that we could. So y'all can see Donna. I mean, if y'all just want to go around, Donna and Crystal are the nurses who review the charts at main campus. So y'all can wait and say hey.
Hello. Hi, I'm Donna.
Hey, I'm Crystal. Nice to meet y'all. Thanks for joining us and inviting us also.
Yes. And then Jamala and Audrey and Monica actually reviewed the charts at Highlands, and Audrey kind of floats between the two. Monica's off today, and I think Audrey, you can see Jamala. And then Glenise and Ryan and I are the leadership team over CDI. So we're just we try to keep, I jokingly say we're the air traffic controllers on most days. So, so we're just these great nurses and everything that they do. So we'll just get started. How about that?
Well, hello again, I'm Donna. So I'm gonna start off and lead out with some of the questions. The first question that we have is that you got asked or needed information on what is needed in the discharge summary to bill appropriately, and are there keywords to state such as improved or symptoms resolved? I know this question was about the discharge summary, but we also included information that is needed on the progress notes. So is it important to state if the diagnosis was treated and resolved, suspected, and or ruled out? If a diagnosis is documented.
Donna, can I stop you for a second?
Sure.
Can everybody put their phone on mute? Because it makes it very difficult to present when you don't have it on mute. Thank you.
Thanks.
Okay, still hear some noise, but do y'all hear me okay?
Yes.
Okay. So as I was stating, that it is important to state if the diagnosis was treated and resolved, suspected, or ruled out. If a diagnosis is documented as suspected at the time of discharge, then it can be coded as a confirmed diagnosis per official coding guidelines. Also important to document after further study, the reason for the hospital admission and all diagnoses associated with the current visit in the progress notes and in the discharge summary. Also, we need to document confirmed diagnosis and the POA status in the progress note, as well as the discharge summary. The next question, could you review the information that is needed in the H&P, explain what is needed in the family history and social history? So for CDI, the information that we need in the H&P is to make sure that the reviewer system and the impression and plan are consistent. For example, the general reviewer system may have patient is awake, alert, ordering ×3, but in the impression and plan, the patient is noted to have encephalopathy and altimeter status. So that would be consider a conflict or maybe a reason why we may be sending a query to ask if the patient actually had encephalopathy. The next thing is review of system need to reflect the diagnosis that the patient has. Another example would be acute respiratory failure to include the signs and symptoms to support this diagnosis in the review system, such as labored breathing and use of accessory muscles. Also include the chronic conditions that are being treated. Another question was about the family and social history. The CDI committee has been working on standardizing the H&P elements. Dr. Glasgow is on that committee, so he will be a great resource.
Yeah, one thing that I'll just add to what Donna's saying is
Part of the distinction here, I would say, is the CDI is looking more at kind of the facility billing. So what gets put out for the case DRG and such. The issues we're dealing with as a group for looking at the information in the review of systems, family history, social history deals with provider billing, which isn't necessarily something that CDI is looking at to check the elements we need for those components of provider billing.
Okay, thank you.
I have a question about the review of systems. I mean, in your HPI, if you talk about their, shortness of breath, dyspnea, or something like that, you don't need to include that in the review of systems, correct? Or do you have to put at least a statement negative except for above and as per HPI?
The thing that we found we see in the review system, it may have that the patient has unlabored breathing and those things. So that's kind of where the conflict comes in, because it may be addressed on admission or in the ED note, but then when the patient gets to the floor, and if it's a new diagnosis, then it's still stating that the patient has non-labored breathing, respirations, even unlabored. So those things are kind of like a conflict, if that makes sense.
Yes, I'm sorry if it's so loud in this workroom, but essentially in your HPI, if you put, patients having dyspnea exertion with labored breathing and blah, 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 if you click on the review of systems in one of those boxes, if you click non-labored breathing, then that just kind of nullifies the whole thing.
We look at the full documentation in the chart, so it kind of has our wheel turning like, okay, so here they're saying that the patient didn't have any labored breathing. But down here it says patient has acute respiratory failure, new O2 requirement. So we need additional information just to make sure that that diagnosis is supported. That way that is not in question on whether the patient truly had the diagnosis. Any more questions on that? Dr. Bringle, went off.
No, I appreciate you. I think that answered my question. I mean, it's overall, it sounds like you guys just need every part of the note to be consistent, even though you might in your HPI say, the patient's coming in here for respiratory distress and blah, blah, blah. And then in your assessment and plan, if it says respiratory distress, blah, blah, blah. But if we click the box, because say we're going through the review of systems and we're just clicking real fast, if we click the box on the pulmonary sector that says like, oh, patient non-labored breathing, then you guys kind of, I mean, do you bill lower because of that? Or do you just kind of double take and say, yeah, that review of systems needs to line up with the rest of the note better? But in the end, like those other details outweigh it, or?
Well, all needs to line up because we are not at the bedside and the coders are not at the bedside. So we're looking at the information that we see in the chart in order to try to make sure that it's supported. The diagnosis is supported.
Gotcha. And for the review of systems, I was taught in residency that instead of having to click, 10 different little bubbles, you can put 10-point or 12-point review of systems obtained negative, except as per HPI. That counts for the review of systems section, correct? Because then that kind of negates maybe the inconsistencies you might see.
Yeah, I would have to say yes to that unless somebody else has an opinion on it. But if the patient doesn't have any abnormalities for us with their breathing or any of the other systems, then I would think that would be appropriate in that case.
Brandon, I'll add to that. I just jumped on, so sorry if y'all said this, but the review systems 12-point is more important for the patient keeper physician billing that IKS does for you, but still the answer is yes. I think that it would decrease the inconsistencies. And on a bigger scale, if everything is consistent, the whole hospitalization, and there's one review of systems that says not labored, we would just overlook that. I mean, we would just, so I don't think that we would have to query you for that one thing if everything else makes sense, because it's impossible to get everything 100% perfect for sure. So if it is a lot of times or a bigger thing like sepsis yes versus sepsis no, then we might have to. But I think there's a lot of times where that small thing it doesn't overrule the rest, that it's very clear.
All right, thank you.
Okay. And let's see, sorry. Can we discuss what is needed for diabetes to be documented appropriately? Diabetes with comorbidities, insulin-dependent diabetic or non-insulin versus non-insulin dependent diabetic. We usually need to see the specific type, 1 versus 2, or sometimes it can be a conflict where type 1 is documented or type 2, both is documented. So that end up being a conflict. We'll send a query for that reason at that time. Also, any comorbidities that are associated with diabetes. DKA needs the POA status clarified. This has the potential to impact the quality scores. If it's not present on admission, it could be a HAC 9.
Can I ask a question about that before we move on?
Mhm.
For DKA, we get a lot of people from the ICU that obviously came in and they're in the ICU initially because of DKA. If they didn't document that, I mean, obviously, if they're in the ICU, do we still need to do POA like in the discharge summary and in our progress notes? Because usually when they come to us, it's obviously resolved or they wouldn't be coming out to the floor.
Yes, you can, and we can capture it from the discharge summary. If we see it during their admission, then we can also send a query to the ICU doctors as well, or ask for clarification.
And just to expand on that too, at any point during the hospitalization, a POA status for any diagnosis can be identified. So when they first come in, a lot of things are differential. And if you determine after further study that, hey, this was POA, you can write that at any point during the stay. It doesn't have to be like on the H&P or the first few progress notes. You can just say, after further study based on X, Y, and Z, this diagnosis was present on admission.
And question on that to help you guys. So Marquita and others clarify if I'm wrong, but if someone comes in and you write DKA on the H&P and every day subsequent, that will automatically go in as POA because they came in even without you saying the letters POA. Because it was within the first 48 hours. And so if it's already documented in the ICU and they come out and they didn't say the letters POA or the word POA, it still will likely be coded as POA because they documented it on day 1.
That's correct.
There's also clinical indicators that have to be present as well. So it's not just a slam dunk. Clinical indicators have to be there, but that helps us out greatly when it's in the H&P.
Okay, next.
Is Crystal? Is that you? I think you're on mute.
What needs to be included for CKD diagnosis? Most of the time, please document the stage if it is known, whether it's 1 through 5 or ESRD, and identify if the CKD is related to diabetes or hypertension as appropriate. All right, so this is our biggest opportunity, and I know there are many people working on this as we speak. How do I document sepsis most appropriately?
Justin, go. Just kidding.
I think you went on mute again accidentally.
I'm sorry.
That's okay.
Can y'all hear me now?
Yes.
Okay, good. Okay, so here at UAB, we do use the sepsis 2 criteria. And as you can see, there's certain elements that need to be present for you to have sepsis. I would say though, this is sort of a checkoff point, but you also want to make sure that you paint the most accurate clinical picture of the patient's severity of illness when the documentation of sepsis is on the chart. And that just helps to decrease the number of queries. And also it gives us a clear picture of what's going on with the patient. It appears that sepsis is being greatly over-documented hospital-wide based on query responses that we are receiving. If sepsis is a diagnosis being considered, then that's great. It's very important to confirm it as ruled in or ruled out, but it's also very important to paint that picture of how sick that patient is. For example, if you have an elderly person coming in with a UTI and increased heart rate and increased respirations, that doesn't necessarily mean that that patient has sepsis, even though it does fit the sepsis 2 criteria. So if you have a patient that is elderly, comes in with a UTI, increased heart rate, increased respirations, has encephalopathy, short of breath, frail, increased debility, the more accurate the picture of the patient is, the more likely that may be a sepsis picture. And that what I described just then could be a sepsis picture. It's all depends on how you describe the patient as well as the sepsis criteria. So that is the reason we put sepsis description of the patient would be helpful. You also want to make sure that you document your infectious source, your clinical indicators, and your treatment. Now, there may be issues where you're not for sure right away whether it's sepsis or not, and I know we get that a lot. If you want to document suspected or concerned for, that's awesome. We appreciate that. But at some point in time during that admission, just let us know, just document whether it has been ruled in or ruled out. And it may just be surge with a response and not sepsis at all. And that's totally okay too. Dr. Glasgow, do you have anything to add to that?
I think that was a great description. And what I would say is kind of the opportunities lie at both ends of the spectrum. It's the mild cases that sort of barely meet surge criteria, and you look at the patient and they're not all that sick, but they do have an infection. Those likely do not meet sepsis because you don't have that sort of overwhelming response. And then less on our service, but certainly we inherit these patients sometimes, is the really sick multi-system issues. And then it's deciding, was that sort of isolated urinary tract infection what really drove the clinical picture, or was it the profound cardiogenic shock? In which case, while you meet all sepsis and shock criteria, it's these other processes that were doing it, and the possible pneumonia or possible UTI just aren't that convincing to think that that was what was making the patient sick.
I'm a little confused on that in the slide before this, because, you know, your description of sepsis sounds like, in my mind, then the only septic patients that we label as sepsis are the severe sepsis or sepsis with organ dysfunction. And we just necessarily don't need to include that first box on this the previous slide before this, because you have sepsis and you have severe sepsis with organ dysfunction and you have septic shock. But it sounds like, in my mind, this first box, you're telling us essentially these patients that maybe fit that first box of sepsis, to not label them as sepsis, and to really only label people as sepsis that are in the second middle box. Is that, am I wrong on that, or?
I do think that is probably a good framework to be thinking about it. There may be folks who only meet surge criteria, but are really profoundly sick, and if it weren't for aggressive resuscitation, would have it progressed quickly. So I don't know that that's 100%, but that is partly the distinction between the SEP2 and SEP3 guidelines. And documentation world struggles because you've got competing definitions and competing pairs who will take one over the other. But I do think many of those cases fall more into the, we should be concerned, we should treat aggressively, but if a patient responds to treatment very quickly, then likely they have an infection, but we were fortunate enough to rescue them from becoming septic.
Okay, and I guess what is the downfall? Like, what is the negative impacts of saying, let's say an elderly lady comes in at Highlands and she is tachycardic, her blood pressure's maybe a little bit on the low side, and she has grossly dirty urine. She's not really like severe sepsis, but you want to call her sepsis because she's sick. She's sick enough to come to the hospital. You're going to give her fluids. But what is the downfall of putting her as sepsis in the documentation? And then, treating her. And again, thankfully, she's not super sick and doesn't need ICU care, so she gets better pretty quickly. Is it that we're missing the secondary documentation of sepsis and that's hurting us in the long run? Or I guess I'm just confused on why you would put those patients as just regular sepsis that improved.
Yeah, so I think there's two parts to that. One is to highlight everything Crystal mentioned, is if the chart doesn't paint that really sick patient picture, then often our payers will not pay the case. And we just had a case that Dr. Taylor went back and forth for the last 3 years before it finally got finalized. So those are patients where our documentation means the system didn't get paid or it was delayed significantly because you've got one thing that says sepsis and another thing that says they're sitting here fine and dandy and no issues. The other reason that I think sepsis gets this extra focus is it's involved in a lot of quality metrics, particularly the Medicare quality metrics, of which right now our star rating is not at all reflective of the quality that UAB provides. Like we've got a 2 out of 5 star rating, and I don't think we are that level of institution. And so when you have these mild infections in an otherwise complicated patient, and that patient is dying from their metastatic cancer, but we say they died from their sepsis, when there's an incidental UTI, then it looks like we fail on those quality metrics.
That makes a lot of sense. Thank you.
Justin, I'm right there. I'm
wanna
a little
point
bit
out-
confused. Sorry, can
I'm
you hear me?
sorry, go ahead.
Sorry, I'm right there with Brandon as well. This is Jill Neely. So what you're saying, just so I understand, is that if they meet 2 out of 4 SIRS and they have like a confirmed like UTI or I don't know, cellulitis, that even if they were labeled as sepsis on admission, we probably should change that to like just call it like urinary tract infection. Or what do we do with that? Because they're not that sick, but they do meet criteria, but they're, responding nicely.
Yeah, I would say if you look at the patient and feel like they don't look sick and probably didn't look sick based on what you see, then I would go ahead and change that diagnosis from the initial concern for sepsis and change it to cellulitis. It is beneficial for clarity in the documentation to at least that first time state sepsis ruled out. That will make it clear that it was intentional on your part to change that diagnosis and save confusion in a query down the road. And part of it is a heart rate of 90 particularly is kind of a low threshold. Like someone who is sitting in front of you with a heart rate of 95 and a white count of 13,000 technically meets criteria, but I think we know that's different than someone who's 130 and 18, but both of them kind of fall into that same category. And so it's an attempt to give thresholds, but there's no yes, no, very clear, this marker means you've got sepsis. And we're just trying to balance aggressive and early treatment with making sure that our documentation meets our payers' expectations and helps us reflect the care that we provide.
Okay, that sounds good. Thank you.
Thank you, Dr. Glasgow. I also want to point out that when severe, I'm sorry, not severe, sepsis with organ dysfunction is documented, we would like for the organ dysfunction to be on the same line as the sepsis diagnosis. And that is just because it shows an association to the sepsis. I know usually, it's labeled underneath, but for professional coding purposes, it should be on the same line with the sepsis diagnosis. And so that's the reason you may get several clinical validation queries asking to identify the organ dysfunction that is associated with the sepsis. Even though we know that it's there, we know that a patient has a lactic acidosis and AKI and hypoxic respiratory failure, we needed to be on that same line. Sorry. Next slide. When a patient is first admitted and we know the patient is sick with some sort of infection, can you discuss how to properly word it from start to the time we get the cultures back? So CDI, we recommend that you state suspected or possible infection. And then once the cultures come back or once the infection has been ruled out, then just document as such. And then just make sure that you're carrying that all the way through to the discharge summary. Any questions on that? All right, please clarify the present on admission statement and when to use it, wounds, infections, labs, etc. Basically, as we were saying, it's important to give the most accurate severity of illness picture when the patient is diagnosed coming into the hospital. So if you have any diagnosis, whether it be UTI, AKI, heart failure, go ahead on that first documentation and go ahead and document that it's POA, first day of admission. That will alleviate all questions that we have about present admission status. Also, if the patient does not come in with AKI, but maybe 3 or 5 days later, the patient ends up with AKI, it wouldn't hurt to say that the AKI was not present on admission. You don't really have to say that because we can go back to the actual clinical indicators and see whether or not it was present on admission or not, but it just helps out. And also with our PTEs, and I know that you don't always know on admission if a PTE is present, due to circumstances. But if you do know, go ahead and document that it's POA.
So I just want to clarify something, actually. I just have a question. So for every patient that comes in, for every diagnosis that they come in with, you want us to put POA, so they may have 6, 7, 8 POAs written on that H and P. Is that right?
Yeah, well, so going forward, we would say yes. It's not completely a guideline at this point, but at some point that is going to be a guideline. So it would go ahead, it would be to our advantage if the POA status was listed, at least on the first day of admission.
And Dr. Glasgow, you could probably speak to this as well, but we are going through, our program we're going through some changes with some different guidance. And I know Dr. Glasgow and Dr. Taylor are kind of heading up that project. And so, there are things that coming down the pike that we know of that are going to be requested of the staff. So we were just, since we had this opportunity to get in front of you, we wanted to kind of proactively share some of these suggestions that are going to be laid out to the staff. And two, to help, as Crystal said, alleviate as many queries as possible. But it goes back to what was said earlier. If something is documented on the H&P and their clinical indicators are there to support it, it's obvious that it's POA, the coding professional can code from that. But it's some of these diagnoses that we don't really know for sure when they first come in, if they're POA or not. Like she said, you may not know that they've got a PTE when they first get there. And it may be after that study, after more, tests are done. Dr. Glasgow, you want to say anything else about that?
Yeah, I'm not sure if I have much more to add. I think kind of my summary is to say a big challenge UAB has is consistency and clarity. And so it does seem a little silly to write POA on all of your diagnoses on your admission H&P, but it just helps establish a statement that then can be referred to later if support is needed, if something drops and then gets added back on, can get confusing. And, you know, particularly for a hospital service where we have multiple people rotate through, we may trade patients back and forth with an ICU. Some of these extra things are hopefully a small time waste that help ensure that everything is just easiest to capture and there's no confusion when someone is trying to figure out a chart 30 days into a hospitalization.
Kim, I've also seen documentation where there's a blanket statement. These conditions are what's present on admission, and then they're listed below. So it just depends on what's good for y'all.
Okay, thank you.
So we've been asked the question, when something resolves, can we stop documenting it and leave it out of the discharge summary? What we recommend is that on a progress note, just make a statement and say that the document has been, that the diagnosis has been resolved. It would be helpful if you all address it on the discharge summary, especially if a patient has been here for a while, has had a long length of stay. But I have been noticing that as diagnoses have been resolved, that word has been beside the diagnosis. And so we can capture that. The only problem is sometimes when it's a long length of stay, it's good to just kind of reflect on, do a summary of their stay and include those diagnoses.
Yeah, and I'll add to that, right? Resolved will be coded as they had it. We had it and we treated it because we're good doctors and it got better, as opposed to a differential. We thought they might have it, but they didn't. So whatever it is, ruled out, you know, shortness of breath, PTE ruled out. And so there is a balance between having a running list in your whole progress note every day and kind of just focusing on what the current active issues are. But to avoid a query, especially for long stays in a discharge, I encourage our residents and everyone else to have, you know, at the bottom a section of resolved issues, and it can be hyponatremia, you already fixed, AKI, you already fixed. That does get perpetuated forward each day in a good way. So you don't have to, the person who discharges them doesn't have to look back through all the notes and make a combination of diagnoses. So that's what I usually advise. And it'll be a one-liner, right? You know, AKI, resolve with fluids, whatever else it is. So resolved means we will code it. Ruled out means we will not code it.
Thank you, Dr. Starr. And so we've also been asked a question about special keywords to document and when to use, such as acute, chronic. Whenever someone has a chronic condition and they have an exacerbation, then of course we need that to be clarified. To say that they have acute on chronic systolic or diastolic heart failure, to state that they have acute pulmonary edema. We're just trying to catch the acuity of the patients that you all are taking care of.
Hello, this is Audrey. How you doing? I have NSTEMI versus myocardial injury. And it's important that we document, if it's an NSTEMI type 2, that we include the clinical indicators such as chest pain, EKG changes, et cetera, to support the diagnosis and the specific cause. We are very well aware that NSTEMI type 2 are typically due to non-cardiac causes, sometimes due to sepsis, respiratory failure. Sometimes patients may have a hypertensive emergency or crisis. And this will put a stress on the heart, and we'll see that reflected by the increase in troponin. But typically that troponin would not have an acute rise and fall, but because it is slightly elevated, it would be documented as a type 2 NSTEMI. So it would be nice if you all agree with that and put that in the chart. But also sometimes patients will have a chronically elevated troponin. And if you know that could be so, please indicate that as well, so we'll know that that is not necessarily related to this admission, but that the patient chronically has an elevated troponin. The other point is sometimes myocardial injury, elevated troponin, or non-ischemic myocardial injury and NSTEMI type 2 are all being documented in the same chart, which leads to conflict, because in the coder's mind, myocardial injury goes to one code and the NSTEMI type 2 has another code. And if they're both listed, they're not sure which one we should capture. And I just like to also add, if you document that the patient has an NSTEMI and you don't specify if it's a type 1 or a type 2, it automatically defaults to the type 1, and we prefer not to have that. But after further study, if you do a heart cath and it's determined that the patient has coronary artery disease and there's an advancement in that, or that they have disease and we need to go in and do a PCI, then of course, if the NSTEMI type 1 is indicated, please document it. And feel free to add any other comments.
The only other thing I would add to that is, like Audrey said, if we don't have it, if it's not specified, it's going to default to the NSTEMI code. And that does impact your 30-day readmission rate. So that's why you may get a lot of queries for the specificity for the type of NSTEMI, because we definitely don't want to, if it's an NSTEMI and they're readmitted within 30 days, that negatively impacts your quality scores. So it's important to make sure that we've got the right type, so we don't get dinged in that area as well. Did anybody else have anything to add to that?
So I think this is our last question, and it's if the phrase due to or likely due to, is it really necessary? Well, yes. Due to and associated with are very necessary to establish a causal relationship. For example, if we see the documentation of a UTI in the setting of a chronic Foley, if that's documented, then that doesn't indicate a causal relationship. So we have to see the words due to. I kind of look at it as, if I have a device, an infection of a PICC line from a yeast infection or something like that, and the physician has to remove the PICC line, we have to be able to identify that there's a relationship. And using the words due to is what really gives us that causal relationship. But we have to realize also, when we see the words likely, suspected, those are uncertain diagnoses. And so if at some point you all decide that this UTI is really related to this Foley, and likely you can stop saying likely at that point in time. But if on the discharge summary, if you're still not sure, still continue to document likely, because likely due to, because we can still capture that. But if that is dropped, like if we just start seeing that the patient has a UTI, or like today I saw a chart that it says the patient has pneumonia, possibly due to the aspiration pneumonia, to aspiration. Well, as long as possibly due to aspiration is documented, then we can capture the aspiration pneumonia. But if on a discharge summary, if it only states pneumonia, then we're gonna have to send a query to clarify if that particular pneumonia is a regular community acquired pneumonia, if it's an aspiration pneumonia. So the same thing with the UTI, we'll have to just make sure there's a causal relationship, that the UTI is really due to the chronic Foley. Sometimes I see UTI/neurogenic bladder with a Foley. Unfortunately, because it says with a Foley, I'm gonna have to send a query, because that doesn't really tell the coders that the UTI is due to the Foley. It just says this person has a Foley, they have a UTI, but it doesn't provide the causal relationship.
And what it boils down to is that we're all nurses, we're clinical as well. So we can put those pieces together. It's not that the coders can't put those pieces together, but it's that they have to follow the coding guidelines. And so they have to have the specific buzzwords. And so unfortunately, at times we have to query for things that are clear to us, but they have to have the specific words to be able to code it appropriately. And then, like Jamala was saying, if the term likely or suspected, if they're documented at discharge, then they can be coded as confirmed. But if it's stated that during the hospital stay and not carried through to the day of discharge, then it drops off. So we would have to clarify that. And that's a little bit confusing. I know Dr. Steinhilber, we've been in many meetings and they're like, well, why is it this way? And why is it that way? And we said likely, but you didn't say it at discharge. So that's another one of those coding guidelines. So
yeah, I'm just going to use that as a jumping off point to acknowledge through all of this, but this one specifically, this is semantics and it is frustrating sometimes. And as a provider, you're like, I said UTI with Foley, like that is due to, and they know that, but insurance companies won't pay for that. So they're trying to assist us in helping insurance companies pay for things. But it's annoying and we get that. And there are some things that are more annoying than others. So I just feel the need to say that because as someone who also gets these queries, it can be frustrating and we totally get that.
So questions, I know there's got to be many, probably.
Kim, I have a question for you. With us starting to have these continuing education, is it going to become a part of where we can send queries to the nurse practitioners?
So that would be something I would have to talk with Cody about. I know currently you guys are just sending them to the physicians. So I can talk with Cody and see kind of what their thoughts are. Because the thing is a lot of our APPs are the ones that do a lot of the H&Ps. And I know they get some queries on the H&Ps. Well, the APPs are the ones that wrote the H&P, not the physician. So I know there's been talk about it. So I can talk with Cody and get back with you about that.
Okay, thank you. As
Yeah,
I know
you can find out
sometimes
about
there.
that. I'll just say though, before making a decision on that, hospital leadership always asks us to query attendings rather than any PAs, NPs, and residents. And we continue to fight that battle depending on the service line and who is more likely to document and things like that. So we can definitely find out from Cody, but we also would have other people that we on our side would have to talk to too.
I've seen a couple of queries where the attending actually forwards it to the APP and then they answer it. So that's the reason I ask. Thank
Yeah,
you.
I think it's hard from an education standpoint. So like this has been great and helpful, but it's always more helpful if you're admitting a patient and someone can reach out to you about documentation that you did. I think it sticks more. And so being a part of that query process is going to be important as an institution as we move forward. So yeah, we'll definitely talk to Cody. But I know that these are also conversations being done at the advanced practice leadership level too.
And Dr. Steinhilber too, as of late, we've kind of gotten the blessing to continue at this point with querying the PAs and the APPs. It's the residents that's where the issue lies. So so I think that going forward, hopefully that will not be an issue because we all know that, the PAs and the APPs do a lot of the documentation. for many service lines, and they are instrumental in the care of these patients. So, but thank you for bringing that up. But I think that's been ironed out a tad bit more. And so the biggest reservation right now is whether to send residents the queries to continue to do that. So of course we have to do what we're asked to do or told to do as well. But thank you for bringing that up.
Thanks.
Is there a way that when y'all are querying that you can query both the attending and the APP who wrote the note as far as like a CC so they can at least see it?
We can do that. The only thing is who's going to take ownership of the query? And if both of y'all answer it, will you give the exact same response? Because if there's a different response when we send it, then that's going to be a conflict. And that's a whole nother can of worms to open. So we can do that, but we would need to know who's going to take ownership of it.
I guess on the other side then, is there a way that either Kim or I could get a list so that we could continue to, like bring up trends to the APPs? Because I feel like there has to be trends that we're seeing, especially with our service in particular.
When you say trends, you mean the types of queries that we're sending the physicians?
Yes.
Sure, yes.
Like, are you seeing that it's always, like, is CKD something that we're always documenting wrong, or that APPs are always documenting wrong?
Yeah, we can send you a list of the most common queries that we're sending out.
That would be really helpful. I think so.
Courtney,
we don't want you guys to get too proficient at this because we need our jobs now.
No, I'm not.
Don't worry. There'll be new hires. Courtney, that's a really good question. And every service line asks for that. And to date, it has been your specific like hospitalist CDI nurse saying, I think that this is what I send mostly. So there's not data that we're able to pull, but we're in the process of we're gonna have to switch systems in the near future. And so there's a lot of work behind the scenes to see what data we can get set up so we can actually send a list easily to say, these are the high points. Because right now, whenever we give that to people, it's Crystal or Audrey or whomever saying, okay, let me think, what do I send the most of? And we certainly can give you what we have. It is just not as organized as it hopes to be in the future.
Yeah, that sounds good. Thank you.
So is this something that's been helpful to y'all?
Yes, it's actually been very helpful. And I know we were talking about possibly doing some kind of education yearly or something with you guys and kind of hoping to get a real good relationship with you all. So, hopefully, as Courtney was saying, is, I know you want your jobs, of course, but, we want to have our better documentation as well, too. So, kind of just having a good open relationship between the two and just kind of getting better documentation. And so, yeah, no, I think this education was really good. So thank you so much. I appreciate it.
You're welcome.
You're welcome.
Happy to do this as often as you would like. And even if it's not something quite this formal, if there's, if you start seeing something, or when y'all get the list that they send you of the things that are most often queried, if you want to have another quick call, we can all hop on a call again. It doesn't have to be like a quote formal presentation, because that's what we're here for. We're part of your team as well, and we want to make things easier for you because we know you have a lot to do, and sometimes answering queries are probably the last thing that you want to have to do at the end of your day. So anything that we can do to help to prevent queries, or to help, explain things better to y'all, we're here. Y'all got a great group of nurses on the hospitalist team, and they're a wealth of knowledge, and they're a great resource for y'all. So so please don't hesitate, to reach out, because we're happy to help in any way.
Great. Well, thank you.
So when they were talking about non-ST elevation MI versus myocardial injury, we had like an education from the people that are doing our patient keeper. And it's probably been, a year and a half or so ago. maybe longer, but they were saying if it's myocardial injury and not a type 1 NSTEMI, don't use non-ST elevation MI. So is that something different, like we've been saying, between our billing versus y'all's coding, or should we be using the non-ST elevation type 2?
If it is truly just a myocardial injury, then myocardial injury is fine, even though the troponins will be elevated. You know, just because the troponin is elevated, it doesn't necessarily mean it's a type 2 NSTEMI. When I used to work with Dr. Bittner, when they look at that, they look for what they call an acute rise and fall when the troponins, you know, go way up. Let's say the troponin goes up to like 80 or 90, and then you gradually see it trending down. They typically call that a type 2 NSTEMI, especially if you have heart failure exacerbation or you have respiratory failure, an acute respiratory failure event, a sepsis event where the patient was sick and it caused that injury to the heart where you had that acute rise and fall. And sometimes you may see some EKG changes, but patients who have CKD as well, they have a more difficult time clearing out their troponins. So you may see some elevation there. But if it is truly just a myocardial injury, it's okay. It's just that when you have NSTEMI type 2 documented by one provider and then somebody else come along and say that it's a myocardial injury, then we have a conflict and we don't know which way to, you know, to code it.
And Dr. Steingilber, do you have anything else to add to that? I know Dr. Glasgow had to drop off.
No, I mean, myocardial injury is second to sepsis in being unclear. But I think what I can't remember what Ginger said was right is there is a difference in myocardial injury and NSTEMI type 2. So we will code those differently. And that's actually really come about in the last few years in order to separate out type 2 NSTEMIs because they were being categorized as just in general NSTEMI. So it was really skewing nationwide everybody's cardiovascular mortality, because if somebody was here for sepsis and happened to have a little bit of a troponin, then the CCU and the cardiologists were being dinged for that death or whatever it is. And so it really was incorrect. And myocardial injury has kind of come since. And so to have an NSTEMI, regardless of type 1, 2, 3, 4, 5, then you've got to have some sort of evidence of like kind of change in your myocardium, meaning an echo, ST changes, something like that. And so if it's just a little bit of a troponin, then the encouragement is, if you think it's secondary to something else and not a huge supply demand mismatch, then to do myocardial injury. But it is not for sure 100% clear because it's just so difficult and also a moving target.
So to add to that, if we have any questions, you know, with the diagnosis that you document, we will query you, and we don't do it to be, you know, difficult, but we're trying to get the clearest picture.
And I'd like to add one thing to that too, y'all. Kim, for your team, if a diagnosis is only mentioned one time in the ED note, and theirs is a lot of differential stuff that they throw in the documentation. If it's never mentioned again, then CDI is probably going to query to ask you, did this patient actually have sepsis, which is a big one that sometimes we only see in the ED's note as a final diagnosis. And then the providing team never mentions it again. So we would have to query. And if you guys were proactive and sort of ruled that out in your H&P, you know, that would save you a query. But I just wanted you to know that just because your team does not restate everything that is documented in the H&P doesn't mean we're just going to pretend the patient didn't have it. So according to the coding rules, there's no rule that tells them it has to be documented more than one time for the coder to capture the code. And so then that becomes incumbent upon CDI to clarify that. So I didn't want that to surprise anybody just because you don't document it in your H&P. If the ED note documented it, then we may have to send you a query to clarify to see if it was ruled out or if it's actually a legitimate diagnosis present on admission.
Okay, yeah, that's good to know. I know I didn't know that. So when the ED documents something, for us to kind of clarify it more in our H&P, if it was ruled out or not. So that's good to know.
That would be excellent. Yeah. Thanks.
I'll say it's buried in there, and we don't expect you to read maybe every detail of theirs. If that is the only place it's written ever and they're here for 2 months and y'all are very clear about anything else, then we go with the people that took more care of them than the 2 hours they were in the ED. So I won't say everybody is equal in that sense, but anything you can clarify, of course, is helpful.
Okay. Does anybody else have any other questions or anything? Well, we really appreciate you taking your time to give the lecture, and I really would like to continue with this, maybe, kind of like you were saying, Marquita, just as needed, or maybe doing something formal, maybe once a year or something like this, with just kind of diagnoses and kind of key things that we've been, that you guys have been seeing from our documentation. So thank you again. I really, really appreciate it.
You are welcome. And
You're so
anyone,
welcome.
we're happy to do so. So just please don't hesitate to reach out.
Thank you.
Yes, thank y'all for your time.
Everybody have a good day.
You
Bye,
too.
everyone.
Thank you.
Thank you, everyone.
Thank you.
Thank you. Bye.